So, good night, everyone. I think that all of our attendees are Arabic speaker. مساء الخير على حضراتكم جميعا وكل سنة وانتم طيبين. Welcome back. Who is raising his hand? And we will start, and we are going back to our mostly 1.5 years to 2 years program. I hope that the screen is clear, and I hope that my voice is clear for every one of you. We as long as we don't have except all the Arabic speaker هنبقى الكلام يعني بعضه عربي وبعضه أجنبي علشان this is mostly didactics موجهة للوطن العربي وموجهة the Middle East region about gynaecology. Simply what we are doing is that we have our ESGO accredited fellowship program. We are accepting 2 fellows every year. And since one of the main items and corners of the program is doing didactics and having the whole ESGO curriculum, starting from the introductions to the principles of surgery, principles of chemotherapy, principles of radiation oncology. And then after that, we are going to shift to ovarian cancer module, to endometrial cancer module, to cervical cancer module, vulvar cancer module, GTN, rare neoplasms. And then we are having modules about the management of complications, about surgical complications, about the toxicity of chemotherapy, and the radiation oncology chemotherapy. And then we are going to shift for some special situations and for psychological support of the patients. So this is mostly that curriculum that will have like 1.5 to 2 years, which is going to be held every Wednesday night. In Ramadan, it will be at 10 p.m. And then after Ramadan, we are going to shift back to our 9 p.m. schedule, 1 hour every Wednesday. The floor is always open for discussions. You can interrupt us. You can write your questions in the Q&A box. And of course, you can raise your hand and we allow you to talk, to ask any question. And it's just like an interactive discussion. And you can speak in Arabic or in English, whatever you want. And all this presentation will be recorded and you'll find it on the website as we're going to say in few minutes.
Basel, may I just highlight that one of attendee is not Arabic speaker, so if we try to sustain it in English, that will be good, or at least part the majority of it.
Okay, so the majority of it will be for English for sure, as long as we try to make it easier for the Arabic residents, but mostly 95 to 99% of our talk would be in English. Okay, but sometimes we will have some Arabic interruptions, so he may forgive us or she may forgive us for that. So again, this is the introductory lecture for our fellowship program. It's Introduction to the World of Gynecological Oncology. And I have put some titles in front of my name. I don't use this so usual to put titles in front of my name. But again, the titles here play an important role because I have got the European board. I have got an MD of Surgical Oncology, MRCS, and I have passed the European Board exam of Surgical Oncology, the ESGO exam for Gynaecological Oncology. I'm the Egyptian Gynaecology Society General Secretary and Middle East and Mediterranean Gynaecology Board member, Pan-Arabian Research Society Gynaecology Steering Committee, ESGO, European Society of Gynecology Council member now, and I'm primarily an assistant professor of surgical oncology in Oncology Center, Mansour University. That's why I feel safe sometimes, or I feel that I have the right to speak about the world of gynecology as I have been going through and through the world from Egypt all around Egypt to the regional experience, some connections and some going in depth into this world. So I'd welcome anyone who want to go for this world, because this world really, we have some problems. Who is interested in gynecological cancer? This is the problems that we are going to speak about. Are they general gynecologists, where the main interest are about obstetrics? We know that the major interest about general gynecologists about obstetrics. And then if they are not interested in obstetrics, they are interested about the IVF, which is much more easier than oncology and other specialties, and is much more fruitful and gaining more and more money. So most of the general gynecologists are more interested in that without being interested in the specialties of gynecology, not just gynecological oncology, but again about urogynecology, about gynecology, about the general gynecological disorders. Some general surgeons go and they interfere and they go to go in gynecological cancer surgery. But again, this is a problem if you don't have the good gynecological background, because I have seen many surgeons who will consider ascites as a stage 4 in ovarian cancer as a stage 4 ovarian cancer. It's just like the gastric cancer, pancreatic cancer, colorectal cancers, because we are used in surgery that all these ascites is a stage 4. Of course, we all know that ascites in ovarian cancer is a stage 1. And even though ascites can be found in benign disease. ما بدري. I will tell you what is Mabadri, what are the Mabadri for all our attendees online just right now. Again, many general surgeons as well as oncosurgeons will consider peritoneal nodules, for example, in ovarian cancer like stage 4 and inoperable, and will send for chemotherapy. And we all know that peritoneal nodules in ovarian cancer are stage 3. Again, many oncosurgeons, not just general surgeons, are interested in doing gynecological cancer surgery. But again, we have this mindset of the oncosurgeons about the resectable, irresectable pattern or the operable, inoperable pattern, that we work hard to change the minds of all oncosurgeons from operable, inoperable, resectable, resectable, to speak in the oncological terms, in the oncological outcome. What's the progression-free survival? What is the overall survival? And what's the oncological benefits, the quality of life, and all of that? So, for example, we are doing many master classes and workshops in our center. And whenever we say, Dr. Khaled Gaballa and Dr. Adel Fathi just say that we have a laparoscopic hysterectomy workshop, you find many registrations. They can't go, they found many registrations. However, when we say that we have a gynaecology workshop or gynaecology masterclass, we just find like 10 to 15 registration, with 5 only coming, and people are not so enthusiastic to come and register for gynecology workshop. So most people are not interested in doing gynecological surgery. So well, to attend these lectures and go through for every Wednesday for more than 1.5 years, is it to be a gynecological oncologist? Not necessarily, for sure. But the most important part is to avoid the common pitfalls that we see every day practice. We see many common pitfalls from the general gynecologist, from the general surgeons, as well as from the oncosurgeons. So at least if you are not going to be a subspecialized gynecologist, you should avoid the common pitfalls through having all the basics of ovarian cancer, endometrial cancer, vulval cancer, cervical cancer, and everything. Because simply, who is a gynecological oncologist? By terms in the USA, a gynecological oncologist is a physician who is specialized in diagnosing and treating cancers that are located in women's reproductive organs. By default, in USA again, gynecological oncologists have completed their OB/GYN residency, then have pursued subspecialty training through gynecological oncology fellowship. And there's some sort of gynecological oncology fellowship that's mostly followed in many countries all over the world. And this is the part that's usually referred to when people say to us, you are oncosurgeons, you shouldn't practice gynecology, because this is a definition that you should have this OB/GYN background. But again, this residency of gynae-oncology fellowship should take 4 years to complete, not 1 or 2 years, but you have 4 years, 3 to 4 years of additional intensive training about surgical, chemotherapeutic, radiation, and research techniques that are important to provide the best care for gynecological cancer. So after finishing your OB/GYN basic training, you should go for 3 to 4 additional years of intensive training. And so when we speak with our dear colleagues from the OB/GYN department, for example, we say that you have the OB/GYN background, but you didn't have the 3 to 4 additional years of intensive training, while we lack the OB/GYN background. However, we had 3 to 4 additional years. We have all our training background is about intensive surgical, chemotherapeutic, radiation, and research techniques for cancer patients. So simply, if you have a general gynecological residency, and then you have, for example, a PhD or MD about something like ovarian cancer or just GTN or something like that, you are not by name a gynecologist. You didn't have all these techniques with complex surgeries, with upper abdominal surgeries, with GIT resections, with urological resections, and all of that. So physicians who complete this training program are eligible to take post-obstetric gynecological board exam and the gynecological oncology board exam, and after that they are certified to be gynecologists. This is the default that we are going to do. So what happened in Egypt that we are going to speak in a few minutes. The practice across the world is different. ده من عندك من الشاشة. So simply we have this practice. It differs from USA to UK and Kingdom of Saudi Arabia, for example. So when you go back just across the Manche from UK to France, for example, you'll find totally different story because most of doctors who practice gynecology in France are surgeons and oncosurgeons by default. They are not gynecologists. So in France, the same situation go for Brazil, South America, Peru, Argentina. So you find all the oncosurgeon societies are very interested in doing gynecological cancers. In Tunisia, Algeria, and all French-speaking North African countries, the main gynecologists are the oncosurgeons, and those who deal with gynecological cancers are the oncosurgeons. In UK and KSA, for example, whenever you find a case of gynecological cancer and then you have to do a bowel resection or urological resection, you must, by law, bring the colorectal team or bring the urologist team to do this. You are not certified, you're not allowed, even if you are a gynecological oncologist, to do bowel resections, to do splenectomy, for example, to do anything in the GIT. And this is a totally different story from what happens in Italy and Spain, for example, because in Italy, they can do the bowel resections. Louis Shiva, as you have seen, has done many urological procedures. He cuts the ureter and repairs the ureter, and he repairs the bladder. He does anastomosis. People do all the GIT surgeries. So whenever we are speaking in Egypt, we must say that a rigid, one-size-fits-all approach usually ends up in fitting no one. I can't just take one model like what happens in the UK and say I'll apply this in Mansoura. I can take one model like what happened in USA and say I'll apply this in Mansoura. I have to modulate to see. I have very good, well-qualified oncosurgeons who have very strong points of doing intensive complex surgeries and chemotherapy and radiation therapy, and I must use them, especially if I had referred and I had transferred many of the young generations, like I'm seeing in front of me right now. Dr. Mohamed Hamdi has been trained in France, in Strasbourg, in the Arcade. I have seen Dr. Khalid Gaballah, who has been trained in Italy, in Gemelli, with Scambi and Fagotti, as well as Khalid Atallah. So I have paid much money for those people from the country, from our taxes, to go and train, and they have learned much complex techniques. They are back in Egypt. I must use them. Not using them and telling them that you are not going to use it to practice gynecology really is a crime. We must go and judge those who will not allow those people who have been very highly trained and specialized to work as gynecology just because the example in the UK is like this. Because the example in France is not like this. The example in Spain is not like this. The example in Tunisia is not like this. So we must see something in Egypt that we are trying to do right now. It's a combination between the oncosurgery background and the good training and fellowship for both oncosurgeons and gynecologists, which is exclusive, it's inclusive, it's not exclusive. There is no discrimination between specialties. Those who are well specialized, those who will give the best care for the patient, will be allowed with the good fellowship and training program to do it. So simply that was my ESGO exam gynecology, and I believe that we are now only 5 certified ESGO surgeons or ESGO gynecologists in Egypt. 2 from our centers are oncosurgeons, me and Dr. Khalid Gaballah. He has passed the exam in Istanbul or in Berlin, I believe. And we have Dr. Ahmed Abdel Muaz. He's an oncosurgeon too from the National Cancer Institute who have passed it in Istanbul. And then we have Walid Al-Amin and Hassan Salman, who are gynecologists, who has their fellowship in our oncosurgery center. So the 5 certified gynecologists, they are either gynecologists who have been trained in oncosurgery departments, or they are oncosurgeons. Those are the only 5 ESGO certified surgeons in Egypt right now. We hope that Amira, Sahara, and Amr will be the next ESGO fellows. I hope that. So the problem of gynecological cancers in Egypt and in the region, the whole region, is the lack of well-constructed gynecological cancer subspecialty in the region, the lack of training programs, curricula, the paucity of specialized centers and units, the shortage of gynecologists who can deal with upper abdominal disease, the unavailability of enough numbers of radiation therapy machines, especially the brachytherapy equipment. For example, in Egypt, we have up till now 3 machines only serving on 110 million population, but now they are being duplicated to be like 9 to 10 in this year. We will reach 9 or 10 brachytherapy machines. with no screening programs. Now this is would be much better with the presidential initiative about cervical screening, and the enormous expense and capping that's happening for genetic and molecular studies. Now everything we are speaking ovarian cancer, about the PARP inhibitors, and about the ADCs, and about the immune therapies, and all of this. In the endometrial cancer, we are speaking about the molecular classifications, and the pol mutation, P53, as we are going to have in the next modules, and then adding immunotherapy, and adding pembrolizumab, and adding immune plus target, and plus blah, blah, blah. And with all the financial situations, things are going very difficult for the low resources setting. So what's the problem of learning and the training in oncology? That's what I have been through for the past 3 or 4 years when I started our training program. What you should remember always, that's never a part-time or subsidiary training. So if you think that you are coming for a center or for a place for 2 to 3 days per week, or 2 to 3 hours per day, and then you are going this for 3 to 6 months and having a certificate, even if you can have a certificate or paperwork, which I believe will happen in Egypt sooner or later, because we give certificates so easy for patients, and then these certificates are not accredited. And whenever they go anywhere in the world, they say that you are not well trained, and this like looks like a closed loop, and they return back to give a very bad reputation about training in Egypt. That's why you should be very strict. This is as we see in USA, they are 3 to 4 years of learning after finishing all the 5 years of residency or the 4 years of residency. So it's like a 7 or 8 years process. So we are speaking about ESGO accredited program for 2 years training in an ESGO certified center. This is a minimal requirement to have a well-qualified gynecologist. Whenever I started the program, many people called me, emailed me, and sent some message for me. Basel, please, we want to join your program. I said, okay, come. And when they come, they say, we will not be available to have a full-time job for like 1 or 2 years just for training. We have our clinics. We have something in the chat. I'll check the chat. The voice is here or gone?
No, we can hear you now.
Okay, now you can hear me.
Yes.
Yes, thank you. So whenever people come for me and they say that we have our clinics, we have to pay for our life expense, for our families, and all for that. And that's why we will not be, it's not easy for us to have this part-time training. And I say, sorry, I can't accept you. I will not have you like for 2 days, for 3 to 4 hours without night shifts, without anything. And then I'll give you a certificate with the stamp of OCMO, of Oncology Center, of Accredited Center, and with our signature. And then you will be not well trained. Whenever you will go, they will say the training is bad in Egypt and the training is bad in your center. What I want is to have graduates like Hassan and Walid, very well trained, having a very good lookbook. And whenever they go through any interview or through an exam, they pass it, and they are the mirror of a sound training. So that's what I do. So I'm so sorry if you are a busy gynecologist or obstetrician or a busy surgeon, you don't have the time or you don't have the luxury to have 2 years of training without having good payment and for training and having night shifts and seeing all the complications. You will not be a gynecologist. This is not for Egypt, this is for any place in the world. So you have this never a part-time or subsidiary training. So if you are not willing or you can't give it the time and the money as well, please forget about it. And you have just to learn and when to stop, when to refer cases, what not to do. And this is very precious, really, just not to do catastrophes every day, what all gynecologists and oncosurgeons see in all the cancer centers about the pitfalls that's being done all over the region, not only in Egypt, okay? So I have to know, I have to learn. That is the value of our theoretical course now. This is a theoretical course. Yes, I have Amira and Sahar, they are our trainees. They have the clinical. You will never be again a oncologist without a good clinical training with a logbook, with operating cases. But again, why I should attend the planning to go for clinical where, either in oncology center or whatever, if you want to go, or at least you will know the basics. You will know when to stop and you know when to refer. Okay, so that's about who is willing to train and educate. You should have the time and the will for that. So what is the aim of our gynecological oncology fellowship? Is to build up a new generation of highly qualified, accredited gynecological oncologists. Because when I started my career, usually, and I meet people from all over the world, they say, does Egypt has a training program for gynecology? And the, the answer up to 2021 was no. Do you have a diploma for gynecological oncology? And the answer is no. Do you have a training program for gynecological or oncology or fellowship? And the answer is no. Do you have accredited center for gynecological oncology? And the answer was no. What we managed to change in our center that from 2021, do you have accredited center in Egypt? Yes, we have Mansoura and Alexandria. Do you have a training program or a fellowship? Yes, we have a training program or fellowship, which is ESGO curriculum and ESGO fellowship, and it's accredited and revised by the European Society of Gynecology. And now we have fellows that are about to certify. Once they publish their papers, the logbook was already accepted and the training program was already accepted, but they need to publish 1 or 2 papers just to be certified and have the European diploma right now. And now we are building on having an Egyptian fellowship, subspecialty fellowship for gynecological cancers for post-oncosurgeons and gynecologists who had the specialty, who have finished already their MD or PhD in OB-GYN or oncosurgery, or finished their Egyptian fellowship or Arabian board for OB-GYN or oncosurgery. Then they have 2 years of subspecialty training and they will be certified. So we are opening more and more chances for better future for highly qualified accredited gynecological oncologists that will reflect the training and the education levels that should be in a big country like Egypt. So again, why subspecialty? This is because up till now in 2024, we have people who argue about the value of subspecialty. And when you are saying we need subspecialty, you find some gynecologists who say, why is the need? What you do more than what I do? I can do obstetrics, I can do IVF, I can do urogynecology, I can do oncology, and I can do everything. On the other hand, you will find oncosurgeons will say that yes, I can do breast surgery, we lost the screen, sorry. The internet connection has. Can you hear me right now?
Yes,
Fatma, Ahmed, or
Yes,
Leila?
we can see.
yes.
Yes. So again, we have the trials every day. So whenever you are specialized in some sort of cancers, breast cancer or colorectal or gynecological cancer, I can say, hi Khalid, have you learned about the SHAPE trial? Has been just published or has been just presented in ASCO 2 days ago. Have you heard about the Interlist trial, which have been published 1 week ago? Something like that. So you know the updates, you know what's happening every day, because you will never concentrate and can follow the updates in sarcomas, in breast, in lung, in colorectal, in prostate. This is totally, totally insane if you are going to follow all of that. And again, it's experience over time. You have the experience, even though I have saying to one of my colleagues, I will not say her name, that even a donkey who will work the same operation every day will be a very good surgeon. I don't believe in that thing about a good surgeon and a bad surgeon and a talented surgeon and blah, blah, blah. Of course, there are talented surgeons, there are better hands. Of course, there is variation between people. But again, if you bring anyone, even if not a physician, and he is doing the same operation every day for weeks and months and years, he will be experienced it and he will do this. So there is no one who is born to be a surgeon, another one who can't be a surgeon. Of course, unless he doesn't want to be a surgeon. Again, there is a very good value of subspecialties about networking. So whenever I'm specialized in gynecological cancers, I can know all the people in my center who are doing gynecological cancers, even we can socialize together. And then by time, and in very short time, you know who are those working in gynecological cancers in other towns in our country. So I know very well who is working in gynecological cancers in the National Cancer Institute, in the Gazik, in Alexandria, in Asyut, in Luxor. And then you are going to know the regional level in Lebanon, Tunis, Iraq, Saudi Arabia, Bahrain. And in no time, because the gynecological cancer world is more or less a small world, you will know the people who work with that in the European Society, in the International Gynecological Cancer Society, in the SGO, and that would give you networking in very short time and research opportunities. You know what is the defect in the field, okay, and then you can see what's the hypotheses that are going to ask, and you can do research opportunities, and all of this will give your patient best chance. Yes. Yes, this is English. اعملوا من عندكم بقى. So, why this specialty? Why do we why this specialty? People think that gynecological cancer is that thing that give you many money. You gain every day hundreds and thousands of pounds or dollars, and you are traveling all over the world, like what Basel is doing. He is one day in Barcelona and one day in Brussels and one day in Tunisia and one day in Iraq, and you are giving presentations here and there. Wow, this is so beautiful, and I want to be subspecialized, just like Nadima Borostom and like Jalit Suhouli and like Anna Fagoti and like all those people who gain lots of money and are traveling all over the world and doing that. However, this is not the true situation, because this is the true situation. The problems are following and chasing you all the time. Gynecological cancer is very exhausting subspecialty. Why? Because simply it needs long training years. It needs long working hours. You have to work very long working hours. It's exhausting subspecialty physically and emotionally. It's very exhausting. Not anyone will withstand the oncological outcome and then your patients and having good relations with your patient and then having recurrences after 1 or 2 years and then losing many of your patients who are already your friends. You have all those complications, you have all those mortalities, and even you can be sued. You can go to the court. I have been to the court twice before for some sort of suing, and then the administration will hate you. You will be the most popular one for the administration. Patients may love you so much, and other patients may hate you, and you have lots of recurrences, and very few people will say bravo or thank you. They will always blame you. So the gynecological oncology life. And you will have very easy this effect of burnout. Individually, you will have mental illness. I believe that many gynecologists have got some sort of mental illness, and people have said to me many times that I'm not so sane. I have some sort of insane. Amira was one of those. Same. Amira. Yes. You can see my screen now?
Yes, sir.
Yes, yeah, doctor.
Yes. So again, gynecological oncology cancer is not a program, it's a life. It's a life where you are going to serve between gynecology with all the gynecologists. They have many friends, true friends from the gynecology. And between surgery, you will go for the surgeons. And between oncology, you should speak oncology, you should speak surgery, you should speak gynecology. So every day I'm in between a meeting for gynecologist and a meeting for oncologist and a meeting for oncosurgeon, and you go and serve between those different lives, between surgeons, gynecologists, and social life with the oncologist too. What you should know after finishing this program, you should know very good what's cancer, what I call the philosophy of cancer. Cancer really is not a disease that you are going to cure or you are going to medicate. Cancer is whole life. Your patient mostly is a chronic disease, and you should know what's the philosophy of cancer, what are the philosophy of guidelines and evidence-based. This is not just like computer or machine that you are entering data and then having the data out. No, this is a patient with perspectives, with emotions, with also, you should know about his social lives. Again, you should shift from operable, not operable, resectable, non-resectable module that many oncosurgeons think about, to know what's evidence-based medicine tell about us, what are clinical trials, what's personalized medicine, what's precision medicine. We should know all those terms by the end of this 1.5 year program. You know the oncological terms. What's PFS, progression-free survival? What's overall survival? What's palliative? Palliative is not end-of-life care. Palliative is totally different story from end-of-life care. What's curative intent? What's the meaning of adjuvant, neoadjuvant, and definitive chemotherapy, for example? Those are all terms that you should know by the end of our program. What are the patient's expectations? This is the most important part. We are treating patients. We are not treating cancer. This is very important. This is the philosophy of cancer. This is what I like, because many of our dear colleagues in Lebanon, in Syria, and in Jordan say Hakim. They say Hakimna, the wise man. The physician is the wise man, or the doctor is a wise man. So I like the word Hakim because this is wisdom. It's all about the wisdom in dealing with cancer, science, all your practice and all your talent to give the best for the patient practice. So again, it's a program that should include having clinics, of course, for gynaecology, having inpatient ward rounds and dealing with the patient pre and post-operative, and the most exciting part and what people think it is the main part, which is the OR. So whenever I have Amr or Sahar or Amira, they want to stay the whole time in the OR. It is not only the OR. It is not only the operative room. You should know that there is a very important dictum in surgery and in gynecological surgery is that decision is more important than incision. You should know that. This is the most important. What I'm going to do for my patient, when I'm going to do that for my patient, why I'm going to do that for my patient, and when to stop and when to do that. This is the most important part, the decision. When to take decision, and then again, as I say, incision, even a donkey who is going to do operation every day is going to be a good surgeon, but never, ever he is going to have good decisions, okay? Because the story is totally different. So I have to deal with the decisions are multiple. How I'm going to learn decisions? First of all, the MDTs. The multiple disciplinary tumor boards, these are very important. I have just been in the MIMAGO IGCS MDT before coming here, 1 hour before coming here. So whenever you see more patients, you are going to be more experienced. So I have my clinic, I see like 5 or 6 patients per day or per week, whatever. But again, if you attend the MDTs, you will find, for example, I have seen today 6 cases with the MIMAGO group. I'm going to see another 6 or 7 cases in the PARSGO group on Friday. I see like 12 cases in the MDT in Oncology Center every Sunday. And then I see the patients of my clinic. So for my colleagues who see patients in the clinics, they are going to see, if they are going to see the same numbers that I see, like 10 every week or 20 every week, I'm going to see another 20 or more 20 in the tumor board per week. This means 80 per month. This means 80 more than about 1,000 more patients who are complicated with different scenarios every year. So I'm going to have a more experience by 1,000 patients who are not my clinic, but I see and I see the decisions and I see the experienced people. So this is very important to attend the MDT, because some people and some of our colleagues, like Dr. Muhammad Hamdi, think that the MDT is a duty, that he is coming and then he is going to tell us his experience if he is ready to do that, okay? No, it's a process of learning, and we all know we are learning till this. We are all the time learning. So it is not only Muhammad to give us your input, but sometimes to hear our output, and it's a chance for you to see more and more patients. So try to bring Khalid Atallah with you and attend the MDT for your sake and for our sake again, okay? Again, we have all this educational didactics. This is what we have done through 2021, 2020, 2022, 2023 for Hassan and Walid. Again, this is the introduction, and then the ovarian cancer module, the endometrial cancer module, the vulvar cancer module. So we give you from our time and our effort every Wednesday night in our auditorium, all these lectures, all these didactics. Again, we learn from this. It is a chance for me to update my knowledge and to revise and to know more, and it's a chance for you to attend all our educational activities. Again, audits are very important because it is not always about morbidity and mortality. This is not a thing in all oncosurgery. So, for example, if I remove the left breast for right breast cancer, there's not morbidity or mortality. The patient will return home in the same day or next day again, but this is without any morbidity or mortality. But of course, this is catastrophe. So what we do in audits is that we say that it is wrong to remove the left breast for right breast cancer patients. Again, doing lymphadenectomy for a case of leiomyoma. You can do lymphadenectomy, laparoscopic training or something like that for a case of leiomyoma, and the patient will go home well without any morbidity. But again, this is unaccepted, and this is a different practice. That's why Dr. Amir and Dr. Sahar will collect all the cases all over the month, and then you will present the case by the end of the month, and then we will audit our practice, and we say, for example, please, why you did lymphadenectomy for this case, why you omit lymphadenectomy for that case, why you did blah 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 for this case, and then we will go for the recommendations every month by the end of the month to see what was happened wrong. What are the ways of education? What is essential for education? This is a screenshot of my mobile phone where I have the ESGO events and the ESGO application on my mobile phone. It's very useful where you find all these algorithms for the guidelines. So these are the applications on my mobile phone. This is my screen. The ResearchGate, for example, very important. Up to date, if you have the access to up to date, please do it. It is very, very, very valuable, especially for those who are preparing researches or presentations, something like that. So try to have up-to-date access. The NCCN guidelines, the FIGO guidelines, and the ESGO Academy. All of these are essential applications that you will have on your mobile phone screen. And a very important value that many people underestimate, X or Twitter, the Instagram, and the LinkedIn. Many people say this is social networking, this is how I just waste my time through going through social media, but really you will really going through X and following all the figures of gynaecology over the world, and then all the societies that I'm going to mention right now, you will see the updates, you will know about the meetings, you will know about the courses, you will see the papers, and once they are published, even before they are published, you are going to see what's clinical trials going on. You will have the chance for some networking. So never underestimate the tools. They can be very, very strong tools for education. Again, I am biased for the Egyptian Gynaecological Oncology Society Facebook page or website, where you will find many didactics, and you will find, for example, if you are following our page, you will know about this course, and then you are going to register. So try to follow all the specialized societies. This is simply the world of gynecology. It's a small world. You should follow and go through the website, and I believe that anyone who is interested should be a member in the IGCS, the International Gynaecological Cancer Society. They have a very good website. They have a very good educational portal, and they have very good tumor boards and fellowships, and you should follow their Facebook, their Twitter page or X page, their Instagram page. This is IGCS. Of course, now I'm very biased to the European Society of Gynaecology, as we are ESGO Accredited Center and being part of the council. So my heart lies here in the European Society of Gynaecology, but really, really, before being council member, I have learned so much over more than a decade by the E-Academy. The ESGO Academy is very important. You find all the lectures and presentations in all the conferences and the courses through the E-Academy. And now the membership for low resources setting is for free for the ESGO. It's for around $40 or something in the IGCS. And you can have special discounts for the IGCS or through the ParsGo or through the RimaGo. You can have a special discount, but you should be member in ESGO and IGCS and use their tools, not just the membership. because sometimes people say that we have done the membership and we are not traveling to the conferences, we don't have discount for the conferences. You have discount for the conferences. But again, it's about surfing through the website, knowing about the accreditation, knowing about the research, and the most important is the educational portal in the IGCS and the ESGO Academy. They are very, very variable for learning. The SGO, Society of Gynaecology from USA, the GCIG, Gynecological Cancer Intergroup, that we are going to have a meeting in Marrakesh in May with the PARSGO, the ENGOT, and the European Network of Young Gynecologists. They are very active. They do many courses, they do many master classes, and they are full of life. Really, the ENGOT is very full of life, and we have many friends there. They do good parties, they could do journeys, and very efficient master classes and all of that. The International Journal of Gynecological Cancer, which is the official journal of the European Society of Gynaecology, as well as the IGCS. It is the official journal of ESGO and IGCS, with editor-in-chief Pedro Ramirez. He is doing great work, and they are doing podcasts, for example, so you can, even when you are traveling from place to place or just in your car and you don't have the time you read, you can just go in your car and listen to very variable podcasts about the most recent things. If you are in the plane, if you are in the train, you can put the just the AirPods in your ears and listen to very good podcasts. And you have textbook, the ESGO textbook, either in paperwork or in USB. You have cancer and pregnancy. You have some books, and you have the Atlas of Procedures of Gynecological Oncology. Don't forget about the ESGO pocket guidelines, the academy, the courses. This is very important. Even we have some Arabic written instructions and guidelines written in Arabic. It was translated by my dear friend Omar Ilwan from Jordan. I hope he is online with us right now with Sarah Nassar. Regional-wise, you have the MIMAGO and the PARSGO, the Middle East and Mediterranean Association of Gynecologists, and you have the Pan-Arabian Research of Gynecology. And really, they are competing together to deliver many research and many educational activities. And what's most valuable and important is the tumor board. We have monthly tumor board, international tumor board, with many experts from all the region, as well as from Turkey, from France, from Germany, from Italy, from USA, very high qualified PARSGO. Here you see Sarah Nassar and you see Dr. Khaled Gaballa sitting with Professor Zannouni from Rome and Professor Jalid Suhouli from Charité Berlin. And we discuss the cases. Every one of you who is attending can go through PARSGO, which happens every third Friday every month, or the MIMAGO, which happen every second Wednesday every month. It was just today, okay? So it's a monthly tumor board. We are going to have our PARSGO this Friday, and we can discuss our cases. You can discuss your own cases, and you can even revise the pathology and use these tumor boards for learning. And of course, they have annual meetings. The next MIMAGO would be in Athens in November. The last one was in Cairo with the Eagles. And the next meeting of PARSGO would be in May in Casablanca. This is our ESGO fellowship in Mansoura, okay? This is our training program that we are starting right now, and we just adopt the ESGO curriculum, okay? We give some advantage for the OB-gynecologists rather than oncosurgeons. We give some advantage for less than 40, for more than this 40, and of course the privilege is for those who have MD fellowship, MRCOG or MRCS. Again, this is the website of the EGOS, egosegypt.com, where you will find a very valuable educational portal with now more than 100 presentations and educational videos, both in PDF form and both in recorded form. You will find ovarian cancer section, endometrial cancer section, cervical cancer sections, and others, and you will find even some master classes and workshops there. This is our educational portal. You just go through the education and resources, and you will have a very good surfing and activities and workshop. This is the breast cancer, ovarian cancer, endometrial cancer, cervical cancer, vulva, and this is an example for some recorded and PDF presentations that you will find valuable. We have a question here that I just want to see the question. Salam, sorry. Do you accept one Egyptian? He is from Algeria. Yes, we have fellows now from Palestine, from Sudan, and from Bahrain. So we accept from anywhere, as long as you are going to speak in English, because I know in Algeria you prefer the French. Okay. So our first ever Gynaecology fellows were Hassan. I believe Hassan was online with us right now, and Walid from Egypt. They did a very good and highly qualified 2 years fellowship, and they passed the exam with very good degrees. It wasn't only like just scientific and meetings and all of that, but again, we had our social life and we had to go around. And again, we have our 2 new fellows. We hope they are going to be 3. Amira and Sahar from Bahrain and from Sudan. And again, it's a social life. You see Amira very happy in the River Nile in Luxor. Again, so it is social. It's not only an educational program. Those are terms, Sahar and Amira, that you should know. What's primary, secondary, tertiary prevention? What's surgical staging? What's debulking? What's cytoreductive surgery? What's primary, interval, secondary, and tertiary debulking? What's systematic lymphadenectomy? What's sentinel lymph nodes? What's lymph node sampling, which we don't use anymore in gynecological cancers? What's multi-organ resection, salvage surgeries, excentrations? What's open surgery and when to do MIS, minimal invasive surgery? What's the risk stratification for endometrial cancer and cervical cancer? What's simple and radical hysterectomies type A, B, C, D, blah, blah, blah? And what's the management of complications? This seems very complicated and very too much right now. But again, by the end of your 2 years, you will find all of this very easy. And if you are following our didactics, you will find all of this very easy. Okay? So just follow us every Wednesday. And I promise all of you that all of this would be very easy and you will answer all these questions by the end of our program. You must speak oncology. You are not only a surgeon or a gynecologist, so you should speak systematic treatment, chemotherapy, PARP inhibitors, target therapy, against the personalized precision medicine, transitional researches, immunotherapies, ADCs. What's ADCs? What's ADCs? مفيش حد يعرف ADCs؟ Antibodies, drug conjugates.
Antibodies, drug conjugates.
Great. مين بيرد، أمنية ولا مين؟
أنا كنت هرد بس
لا
في دكتورة سبقتني.
Laila. Okay. So what I usually tell my colleagues, Umniya and Laila, Umniya is a medical oncologist and Laila is clinical oncologist. Umniya is medical oncologist from the NCI in Cairo and Laila is a clinical oncologist from Alexandria. What I usually tell that gynecologists or oncosurgeons, they attend the meetings and conference, and once we speak about systemic treatment and chemo and target, they just go out of the room. They don't want to hear. No, you must speak oncology. You must speak their language. You must master it more than them, and you use the clinical trials more than them, because we have paucity of holes. Those are subspecialized, so you can really correct some or update them about what's happening or something like that. So you should speak their language عشان ما حدش يضحك عليكي. So locally we introduced the subspecialty. We have done 6 years of monthly gynecological oncology forums, weekly tumor boards every Sunday. Just you will come to our center at 12 p.m. and we are good in making it at time, not like Dr. Amira. Amira جاية متأخر 5 دقايق. ماشي. This is our team. Dr. Adel Fathi, who has been very well trained in India and France. Dr. Khalid Gaballah, who has been very well trained in Italy. Dr. Bahaffar has been very well trained everywhere. Dr. Khalid Atallah has been trained in Italy. Dr. Muhammad Hamdi has been trained in France. And Dr. Assam and me, we have been, this is our team of young people, generation, of course, led by our professors and our seniors who have helped us so much. So we have been celebrating in 2018. That was 2 years of continuous education. It's now 8 years, not 2 years. This is Dr. Khalid Gaballah speaking. We have many workshops, and we have our annual go that started in Mansoura in 2017. Then it was in 2018 about ovarian cancer, endometrial and cervix in 2019. And then in 2020, it has been like IGCS, ESGO, PARSGO. And then we launched the Egyptian Gynaecological Society in the 5th in November 2021. And the 6th was in 2022, and 7th was a very big hit with Samima Go in December 2023. It all started by sponsorship of a family who has lost their mother for uterine carcinosarcoma. So the first go was done in Mansoura, not sponsored by any pharma company or any registration, but sponsored by a family of a patient who lost their uterine carcinosarcoma. It was in 2017, here just in this auditorium in Mansoura. And then the second was in Cairo. The third was in Cairo, of course. Totally sponsored and carried by Cairo Journal Club, whom I did so much. I owe so much for Cairo Journal Club team, because without Cairo Journal Club team, this would never have survived and gone through. This is the 4th, the 5th, the 6th, and then we had Anna Fagotti, we had all the ESGO team by the pyramids and by the River Nile. And then the 7th was a very big hit with the presence of President-elect of IGCS and the President-elect of ESGO, both physically in Cairo. They were there in Cairo with more than 50 international experts. This is our monthly online tumor board that I invite everyone to go through Parsigo and Mimago. What we can offer for all of you, free invitation for all our activities. Most of our activities are free of charge. We don't have any money. Or our online webinars and tumor boards, all our training programs, and we have all those courses for basic laparoscopy, for imaging, for all specialties. It's multidisciplinary. So even for radiologists, we have ovarian cancer imaging, we have laparoscopy workshops, we have pathology workshops. We are going to have another pathology workshop in May. We have done workshops in Upper Egypt, in Luxor, and in Aswan, and in Asyut. We have done brachytherapy workshops in Alexandria for radiation oncologists. We have done genetic counseling workshops. This one was AstraZeneca for genetic counseling and how to create a new generation who can deal with genetic counseling. We had master classes, endometrial cancer master class. We had an lymphadenectomy master class in Okmo here about lymphadenectomy. That was the first central lymph node ever done in oncology center by Dr. Khalid Gaballa, but I was in this photo. We had the multi-organ resection advanced workshop. We had a series of oncofertility Egyptian professional network. We had a live transmission of ovarian cancer surgery from our OR all over Egypt, so anyone can find it at home. And just in last month, we had another radiology endometrial cancer workshop. We had some webinars, Dr. Rautaifi from Liverpool, Dr. Ahmed El-Ballat from Switzerland. So again, try to have a mentor. Radwa will give me this slide. If you leave a meeting without a mentor, with a mentor, feeling like your possibilities have narrowed rather than broadened, you know you have got the wrong mentor. The wrong mentor should always broaden your possibilities, not narrowing them. This is a paper that was just published last month in the New England Journal of Medicine. So again, you should find a mentor, you should follow a mentor who will broaden your possibilities. This is our certificate of accreditation in 2021 for the Surgical Oncology Unit in Oncology Center, and this is our white paper about our experience, which was published in the International Journal of Gynaecological Cancer by Dr. Muhammad Hamdi and all the group. And then I was lucky enough after all those years to go by the shoulders of the giants, Jahid Suhouri, Nilem Brostom, everyone, to be part of the ESGO Council member serving starting from this month till 2028. And my last slide is here. Stay away from negative people. They have a problem for every solution. Remember this, very good, very good. This is my main dictum. Stay away from negative people. They have problem for every solution. Don't let anything stop you. There will be times when you will be disappointed, but you can't do anything. Just make yourself the best of that. Make out of what you are. You are the best. And I'm waiting for all your questions and everything that you want to ask.
outstanding كالعادة دكتور باسل يعني يعني محاضرة كويسة لأي حد طبعا عايز يبدأ البروجرام. أنا حضرت تقريبا معظم المحاضرات اللي فاتت، وفعلا مستني إن أنا أبقى معاكم أونلاين، إن أنا أسمع محاضرات وأبقى updated وأعمل update لمعلوماتي يعني. thank you for this lecture.
شكرا يا احمد جدا على يعني انت وجودك على طول معانا، وانت قلت محاضرات معانا في الكورس اللي فات، واتعشم ان انت تكون معانا الكورس ده. احنا دي مجرد انتروداكشن، بعد كده نبدا بقى الشغل بجد، المحاضرات بجد from next week. Introduction to medical oncology and chemotherapy world, and then introduction to the radiation oncology. So mostly this was just an introductory presentation. I want to hear if there is any questions. You can raise your hands. I can